Good evening, everybody. Thanks for viewing my final presentation for this course. I'm going to talk about the placement of the nasogastric tube. This presentation could be given in clinical skills lab and would be aimed towards junior level nursing students as they begin their clinical rotation. So we're going to start with objectives. At the end of the presentation, the student will execute proper NG tube insertion and placement on a mannequin. That is the psychomotor domain at the precision level. The student will recite the steps for placement of the NG tube, and that's the cognitive domain at the knowledge level. And then lastly, the student will apply troubleshooting techniques when NG tube insertion fails, and that is the cognitive domain at the applying level. So for these students, we would want to make sure that they understand the indications of NG placement, and there can be a couple of them. In my research and practice, I've seen a couple different ones listed here, so that could be insufficient PO intake, whether that is a behavioral thing or an inability to consume the right amount of calories, or there could be lots of different things that go into that, but that would be a big one. Another indication would be to evaluate gastric contents if you needed to kind of see what's going on in the stomach and do any testing on the gastric contents. That would be a way to access them. It's fairly non-invasive. Another indication would be motor dysfunction, so whether that's the inability to chew or swallow appropriately or feed themselves. It could be a lot of different things. We also use this on babies a lot when they are just trying to gain weight, and then I've also seen it used on burn patients so that they can get enough calories in, especially when they don't have the full use of their extremities. The last indication would also be gastric decompression, and that would be in the case of a small bowel obstruction or anything like that, an ileus or something like that, where you just need to take things out from the top end while the bottom end heals, I guess. So next we're going to go over the steps of how to place an NG tube. The first step would be to gather all of your supplies. You can see them listed here. That would be the Tegaderm or Hypafix to secure the tube, scissors, Duoderm, an NG tube itself, pH strips, an oral enteral syringe. We use the Infit syringes that are pictured here on the right. You would need a packet of lube, a permanent marker, water for the tube and for the patient, and then a safety pin. The second step is to measure the appropriate length for tube insertion and mark it with a permanent marker. So you will take the tip of the tube and place it at the tip of the nose and measure back to the earlobe and then down to about 2 inches below the xiphoid process of the sternum. That's going to give you an approximate measurement for where the tube would land in the stomach. This is approximate as anatomy is a little bit different. And you can kind of do some troubleshooting things later on, but that's a good way to get a pretty good guesstimate. The third step includes a couple of little things here, one of them being flush the NG tube to prime with water using that Infit syringe. That's going to make sure that you're not giving them a large air bolus through that tube when initially inserting it, and that can be pretty uncomfortable and cause some gas pain for the patient, so we'd want to avoid that. Another part of that, step 3, would be to cut your Duoderm and Tegaderm to the appropriate size for your patient's cheek. Obviously, you can get creative if you want. I work in a pediatric hospital, and we have lots of fun things that we do with our Tegaderm or Hypafix to secure those tubes, because they're not the funnest things for these kids to have. And then you would also want to lubricate the tip of the NG tube to allow for a little bit of smoother transition. Step 4, you would insert the lubricated tip of the tube into the patient's nose, and then have the patient swallow their cup of water as you advance the tube to that pre-measured line from step 2. So that swallowing kind of closes off the trachea and has the patient open up the esophagus and kind of move things down, almost like peristalsis, to get that tube to the bottom. If they are compliant, that is a great way that they can help you. The 5th step would be to confirm placement. So there's a couple of ways of doing this. You can either do via x-ray to confirm that the tip of the tube is in the stomach, as shown here on the right. You can also flush that tube and then try to aspirate some of the gastric contents to measure the pH. The stomach contains gastric contents with a pH of 5 or less. So that will correspond with a color on your pH strip bottle. You can match it to, but you want to make sure that it is 5 or less. One way I learned to confirm placement in nursing school is to listen for a bubbling when inserting an air bolus into the tube, but that is no longer recommended to confirm placement. I think there can be a lot of complications with that, as the stomach is constantly gurgling and it's hard to definitively say that that was the air bolus you were inserting and not one of the many other things going on in the body. So pH or x-ray is preferred. And then step 6 would be to apply the Duoderm to the cheek and then secure the tube to the Duoderm with the Tegaderm or Hypafix, whatever your facility prefers or whatever you prefer as the healthcare provider. And then you can loop that tube over the ear and secure it to the back of the gown with tape and a safety pin. Duoderm is used because we always are wanting to protect the skin of our patients, as it can be very fragile, and having a tube taped to your cheek could cause breakdown, especially when some patients have their tubes for weeks on end. So the Duoderm is just a hydrocolloid dressing, and that acts as a barrier to the skin. So there are a couple things that can go wrong when inserting an NG tube that we would want to anticipate. If the tube were to coil in the mouth, obviously that's not the ideal situation. One thing you can have the patient do is to chuck their chin to chest to kind of close off that trachea and let the tube go down the esophagus. You could also encourage the patient to swallow as you advance the tube. So what if the tube is inserted into the lung? This is a huge patient safety hazard, as if you were to flush the tube or start a feed, you could cause pneumonia or infection or drowning, I guess, to have all that fluid in the lungs. So you want to make sure that you don't do that. You would want to monitor your patient for any signs of respiratory distress, new onset of coughing or difficulty breathing, drop in O2 sat. Sometimes that won't happen, which is why it's really important to confirm your placement with either x-ray or pH. So another way, or another thing that can go wrong is that your aspirate pH could be greater than 5. What that tells us is that it's likely not in the stomach. It could be in the lung, and like we said before, that's a safety hazard. So if it was greater than 5, I would recommend pulling that tube and trying to drop a clean one. What if you cannot flush the tube or obtain an aspirate? This could be a couple of things. With a new tube, it's likely that it is stuck against the wall of the stomach, and when you are trying to aspirate, it's just kind of pulling up against that wall a little bit harder. So you want to be careful here and not try to aspirate too hard if you're not getting anything back. But you can try to pressure flush with a quick pressurized squirt of the sterile water. You can also try to pull the tube itself back a couple of millimeters and see if you can get any aspirate or are able to flush any better. Another thing that can happen is that when trying to aspirate, the syringe snaps back instead of drawing out fluid like you would expect, and that would tell us that the tip of the tube is probably through the pylorus into the small intestine. That's not where the typical NG tube is ordered to be. So we would want to make sure to pull that tube back a couple of millimeters until you're able to obtain an aspirate, or at least are not getting that snap back. Sometimes a tube can be ordered as transpyloric or postpyloric, and that would be a lot of times in the case of or gastric motility disorder. So, if you guys have any questions, I would love to hear those in your responses, and I would also leave time for these students to ask questions, as learning a new skill always comes with many questions. And then here are my references. Thanks you guys for watching. I look forward to seeing all of your presentations. Bye-bye.